And that takes us nicely to 9 a.m. in the UK. And welcome everyone who's just joined. And thank you to all who've been up in your afternoon and your evening from the Asia Pacific region. I'm Adelina Comas-Herrera. I'm the director of the Global Observatory of Long-Term Care. And my colleague Naz Salehi, who is really also at the heart of the observatory, is going to present on what's the observatory and share with you.
Perfect. Okay. Good morning, good afternoon, and good evening to everyone joining us from around the world. Welcome to this special 13-hour webinar celebrating the UN's International Day of Care and Support. My name is Naz, and I work alongside Adelina Comas-Herrera as she is the director of the Global Observatory of Long-Term Care. And together, we're delighted to open the Europe and Beyond session of today's global event. Our mission today is simple yet powerful: to change the narrative on care and support worldwide. But before we go into further details about today's event, I want to first explain what the GOLTC is. So next slide, please. The GOLTC is a platform for cross-national learning. It is designed to improve and strengthen care systems globally. Our goal is to identify shared key challenges and showcase how different countries and communities are addressing them. This is an open space for anyone interested in long-term care, including policymakers, people involved in industry, advocates, care professionals, and academics to share knowledge and foster collaboration. Next slide, please. The GOLTC thrives on the willingness of its members to share knowledge and experience. We share publications, build country profiles, and host blogs and guides on key topics and methods. At the heart of the GOLTC are our interest groups. So these groups organize webinars, share resources, and collaborate on issues that matter most to them. And we have a large variety of interest groups that all members are encouraged to join, steer, or consider making their own. This is a space for learning, connecting, and driving change together. Next slide, please. So looking ahead, we have an exciting lineup of webinars for the upcoming year, and this is building on the success of having more than 36 webinars this year alone. And I'll share links in the chat so you can explore what's next. But for now, I'll pass it over to Adelina Comas-Herrera to tell us more about today's event.
So today's theme is changing the narrative on long-term care. And what we want to do is to really think through some of the ways in which we can change the quite negative language and thinking about long-term care. So the day has been organized around myth busting. We started in Australia about 2 and a half hours ago. And we're now moving to the Europe and Beyond session, we call it, because we will also have presentations from other parts of the world. And we will end the day in Chile in Spanish. And I'm just going to very briefly take you through the myths that we're trying to bust today and some of the positive and alternative framings we want to explore with you through this event. So we started with a session hosted by the Asia Pacific team on We Are Not All the Same and Care Should Not Be the Same for All, exploring culturally safe care. We then heard just now about how long-term care is mostly community care and the power of community approaches and also what people can do to take some control over their care. We are now just about to start the next session, which will be focusing on the European care strategy. The title is Turning Challenges into Change, EU Supportive Pathways to Long-Term Care Reform. And here we're looking a bit at the myth that it's so difficult to reform long-term care. And in some countries, they seem to think it's impossible, like in the UK, where I'm based. And it's great to see some really positive examples coming through. You're going to hear from Bulgaria and Slovenia. We're next going to hear about a bit of a debate or some different perspectives on sustainability. And there is this myth that it's unsustainable to invest in long-term care. It was already quite well busted, I think, by our Philippine contributor earlier. And we're going to see and think about sustainability from different perspectives. The next session is the Danish reform of the long-term care system for older people, and we're very honored that Minister Mette Kierkegaard is going to present. We're then going to have something quite different. We're going to watch a film and then have a discussion with Teun Tobes, who's somebody who's really working hard to change the narrative through his theme of human forever. And you'll see a bit more what is meant by that later on. We'll then think about the need of long-term care. Maybe that's something that we take for granted, that we will need it no matter what. Actually, there's quite a bit we can do to reduce, postpone, and even how we think and conceptualize care has a big impact on people. We'll then go and talk about stigma, about the traps of ageism, ableism, and stigma, and how that's really something that we're creating problems for ourselves unless we address them. We'll then bust the myth that informal care is free. It isn't. It's not free. It's not even cheap. And we're going to show you some really strong evidence on this. Long-term care jobs are skilled. People who work in this sector have incredible sets of skills that are often undervalued. And we'll also address the myth that these are jobs that people don't like to do. Actually, we have some great examples of the difference, and we will have a contribution from the author of Every Kind of People, who's a home worker who has written about her experiences. We will then think a bit about what people can do to prepare for when they need care and help themselves and help each other, and how, of course, public support also helps. And that will be the end of the European session. And then we're going to move to Latin America. So we're going to hear about, and that's Spanish speaking. So if you are practicing Spanish, do join. It will be great. We'll hear about long-term care systems in Latin America, and then a bit of a rethinking of care from a structural point of view. So that's the end for today. And I have an announcement to make. We have a new group, and that's thank you to Teun Tobes for inspiring us on the importance of film in sharing the messages and changing the narrative about care, and really bringing care alive and bringing the people involved in care, both as people who use it, people who provide it. And so with this group, we are going to start as what we call an interest group. So we want to show and discuss films and documentaries. We want to build a repository of publicly available relevant films. So if you know of any, you can start sharing with us straight away, put links on the chat. And we're also looking for people who may want to be part of the steering group of this. And we are quite ambitious. We're thinking that at some point we might even be able to host a film festival and do it both virtually and perhaps in person. So do watch this space, literally, and do send us any examples of films that you may have. I'd like to end by inviting you all to join us. We have a form that you can use to join the Global Observatory of Long-Term Care. It's free. It looks a bit academic at the moment, but if you're not an academic, just fill the bits that are relevant to you and that are strictly necessary. We want as many people as possible to join us. We're already, I think as of today, 670 people from a really big range of countries. I think at least we've got about 50. And I'd like to also say that we are really, really thrilled that today we have had, I think, almost 400 people signed up for the event. And we are spanning 59 countries in the registrations. Of course, not everyone is joining at the same time because we're in different time zones, and people will be able to catch up on our video recordings. So I think that is all from me. We're a bit ahead of schedule. I don't know if if Flaviana and colleagues are ready to get started for our next session.
Sure. Good
Yeah,
morning,
Flaviana. Good
good
morning.
afternoon, and good evening. Hello to everyone. I'm absolutely ready and eager to start the conversation.
Amazing. Thank you very much, Flaviana. So it's my pleasure to introduce Flaviana Teodosiu from the European Commission at the DG of Employment. And I'm really grateful to her for helping us curate this session. We're going to look at how the European care strategy is really making a difference in terms of the supporting countries in the process of reform. So it's all yours, Flaviana.
Thank you very much. And thank you, Naz, for helping out with the slides. Yeah, so I'm very happy to join this marathon. I've been listening a bit from before, and I was thinking that if I was to summarize a bit the rationale of this session, it would be simply to illustrate how the Commission and the member states are playing a part to changing this narrative, and we very much stand behind your overall goal in this marathon session. So our session will explore how the Commission supports long-term care reforms and investments across the EU member states through the care strategy, as you've mentioned, and hopefully you can gain some insight in practical tools and practical recommendations that the Commission has been sharing with the member states throughout the last couple of years. So building on this EU level perspective or background that I will lay out for you in a couple of minutes, 2 member states will present the reforms, then they will share their lessons from implementing long-term care reforms. So I'm very honored to be joined in this session by 2, what I would say, colleagues from the national administrations, Mr. Ognian Droumev, who is a state expert at the Social Inclusion Directorate in the Ministry of Labor and Social Protection in Bulgaria, and Tina Lipar, Undersecretary at the Ministry of Solidarity-Based Future, a very nice name, in Slovenia. So hello to both of you. I already see Tina. I don't see yet Ognian, but hopefully you are somewhere there as well. Maybe if we go now to the scene setting presentation on the EU level agenda, Naz, thank you. Basically, the purpose of this slide is to illustrate a bit how the incremental evolution of long-term care in the EU policy agenda. So to start, the EU has a subsidiarity competence in long-term care. The design and the management of social protection systems, including long-term care, remains with the member states. So what the EU can do, we can support and complement the activities of the member states and provide analysis and policy guidance. Now, in a historical perspective, LTC is a relatively new policy area at EU level, but it progressed very fast over less than a decade. And basically, the flash that you see illustrates a bit the starting and the ending point. So we started from joint analytical work with the member states in order to really understand the area and be able to interpret things in the same way, to really think from the same sheet. And this has basically been done through joint reports between the Commission and the member states in the context of the social open method of coordination, but also throughout time. So since 2014, we have moved towards more assertive and, I would dare say, supportive approaches, which materialized in the European Care Strategy and the Council recommendation that I will be presenting a bit in more detail later on. So next slide, a few words about the Council recommendation. This is the first ever initiative of this kind, basically anchoring long-term care as a priority areas for the modernization of social protection systems across the EU. Its objective is to improve access, as its name is saying, to affordable, high-quality, long-term care for all people who need it. And basically, on the slide, you see the main building blocks of the recommendation. The first of them is about adequacy of social protection for long-term care. And this policy objective is translated maybe in 3 subsidiary objectives that revolve around timeliness of the intervention, around the fact that the services and the needs assessment should be comprehensive, and also very importantly that care should be affordable. The second block revolves around the availability of care services. Basically, member states are recommended to ensure that the overall volume of LTC services provided are commensurate to the needs, that within this increasing volume, there is a balanced mix of long-term care options and care settings, that ICT and digital solutions are leveraged to make care more accessible, especially where there are territorial gaps. And overall, there is a policy continuum around the care interventions and not separate fragmented types of interventions. When it comes to quality, the recommendation calls for 3 specific elements. First of all, the ensuring high quality criteria and standards in all long-term care settings, which are tailored to the specific characteristics of those settings, and very importantly, are applied to all long-term care providers, irrespective of the fact whether they are public or private. The second requirement or recommendation revolves around the setup of national quality frameworks for long-term care, and in order to make this work, we need quality assurance mechanisms. So that's the third component of the quality recommendation. When it comes to workforce, there is a double focus. First of all, it's about ensuring that jobs in long-term care are quality jobs. And that means having good working conditions. That means having attractive wages. That means having adequate OSH standards, and all of this. In all of this, social dialogue and collective bargaining plays a key role. And then, equally important, member states are recommended to step up the professionalization of care to address skill needs through education and training and career pathways and upskilling and reskilling, but also pathways to regular employment for undeclared workers, and equally legal migration pathways, because in case the national pool of workers is insufficient, which is often the case across the EU member states. When it comes to informal carers, the recommendation requires that member states have clear procedures to identify who they are, because this phenomenon is often invisible in the policy making and in the statistics. And once they've done so, to support them in their caregiving activities through access to training or counseling, psychological support, respite care, very importantly, but also balancing work and care responsibilities, leaves, and access to social protection. So this is a crash course on what the recommendation is inviting the member state to reflect in their national long-term care systems. Now, in the next couple of slides, I will just show you how these different dimensions project when you look at long-term care statistics. Thank you, Naz. Here we are looking at adequacy of long-term care. Basically, the key message of this slide is that financial reasons across the EU member states remain the main reason for not using more professional long-term care, especially home care. And it's also important to highlight the socioeconomic gradient that often characterizes access to long-term care, because it's more poor people who need long-term care on one hand, and then it's also more poor people who have unmet needs on the other hand. The graphs that you see illustrate the key role of social protection in ensuring affordability of long-term care. And basically, it shows how much social protection covers across the different member states. You also see the huge degree of variation across the member states, so how much social protection covers from the long-term care costs, and how this is reversely proportional to the out-of-pocket payments that people have to take out of their pockets to pay for care services. So here we see that basically low public support is correlated with very high out-of-pocket, which basically can push people with long-term care needs into poverty. Moving on to availability, these graphs shows basically access to home care in 2019 across the EU space. We see that basically this is about access to long-term care for people with severe difficulties in ADLs, IADLs. That's very important maybe to start. And then we see that the EU average, which is about 29%, close to 29%, covers very big discrepancies from between member states. In some countries, we have over half of the people with long-term care needs accessing home care. In some countries, we are under 10%. Overall, it's good to mention maybe that nearly 1 in 2 persons with severe difficulties in ADLs, IADLs across the EU report an unmet need for help. So this is the reality as of today. Moving on to workforce. So long-term care workforce, I would maybe just start by saying that despite the fact that the sector has a huge job creation potential, there are huge shortages in the sector. And these shortages are basically driven by difficult working conditions, by low pay, by inadequate career pathways and reskilling and upskilling opportunities in the sector. The graph that you see basically shows how many long-term care workers are there in the member states per 100% persons age 65 plus. You see here that while the EU average stands at around 3.3, this covers again a high variability ranging from 0.3 workers to 10.4 workers from one spectrum to the other. Next slide, please. When it comes to informal carers, basically here the main takeaway message would be that there are gender gaps all across the different types, different intensities of informal care provided. Approximately at EU level, 17% of the population provide informal care once per week. And here we already see a 5% gender gap, but these gender gaps widen for certain age bracket, the age bracket between 45 and 64. So it doubles. And then we also see the strong impact of high intensity care on informal carers' health and well-being and ability to combine work with caring activities. And here we see on the graph how basically these gender gaps look. For high-intensity care, it's 7%. It's 20% for female and 30% for male informal carers. Quickly moving on to expenditure. Here, the takeaway message is really how in many countries, adequate and sustainable financing is a major challenge given public budget constraints. We have a new average of 1.7% of GDP spending on long-term care, but this again covers large disparities between nearly 4% in the Netherlands down to 0.1% of the GDP in Greece. The color coding basically serves to indicate how residential care gets the lion's share of the total expenditure. Some 46% of total expenditure goes to residential care, followed by home care and then cash benefits. Moving on, after this very quick diagnosis of how the EU level picture looks and how member states find themselves in this EU level picture, national responses. National responses is really about how the member states have shared that they intend to implement the Council recommendation. They submitted all the 27 of them submitted national implementation plans. And on the slide, you see a little bit of a top of relevant policy measures reported. We see that basically workforce and availability of services are at the top of the policy agenda, with more than 2/3 of the member states having reforms in this area. But we also see that about half of the member states report measures related to adequacy, to quality, and to support for informal carers. They also report challenges that relate to, in many cases, to the systems fragmentation, to the fact that the right balance needs to be struck between the national level and the regional level, and the budgeting has to follow the different levels. How the digitalization in the sector is still not fully tapped in, and also how the admin capacity sometimes is not there to implement the reforms that look very well on paper, but then fail to really translate in concrete outcomes for persons with care needs. Moving to the last 2 slides of my presentation, a few words about EU-level support actions under the care strategy. So what do we concretely do to support member states implement all of this? A traditional way in which the European Commission supports member states is really the mutual learning aspect. We organize with long-term care coordinators in each member state's mutual learning workshops. We've worked on quality together, on the social protection for long-term care, on workforce. And we are looking forward next year to engage in mutual learning on availability of long-term care and also digitalization. We work with international organizations, OECD, WHO, but also with the Global Observatory on different types of projects. With OECD, we are assessing the effectiveness of social protection for long-term care, and with WHO, we are developing, let's say, more practical tools. An example could be the state of long-term care, which is a self-assessment tool for identifying strengths and weaknesses in the system. But also, as a second example, an online training course for informal caregivers that is already launched, is recently launched, already available in English, and soon will be available in French and Spanish. We also support at EU level different workforce-related initiatives. I was mentioning earlier the importance of social dialogue. So as part of the care strategy, or as a deliverable of the care strategy, a sectoral social dialogue on social services has been launched 2 years ago, which is now producing concrete results and engaging trade unions and employers in a conversation about how to improve the working conditions in the sector. And also, when it comes to skills, we are funding and supporting a large-scale partnership for skills in long-term care, which brings together providers and social partners and basically provide trainings to long-term care workers across the EU space. Funding is very important. We have a range of EU funding supporting long-term care. Maybe just to put a number on this very abstract list of acronyms, it's nearly 15 billion euros from the Social Fund and the Recovery and Resilience Fund have been injected in long-term care systems across the EU space in the time span 2021-2027. And finally, my last slide is about the, let's say, more evidence and knowledge-based consolidation that we are doing at EU level in cooperation with many relevant agencies like CEDEFOP, Eurofound, EUOSHA. So we are constantly working on studies and policy briefs. We are also trying to improve and harmonize and make more timely the long-term care statistics. And perspectives for the future, we will report in 2027 on the implementation of the Council recommendations. So there will be a Commission report that we will submit to the Council, and we are going to try to integrate long-term care analysis together with pension analysis in what will be the triennial report on adequate social protection in old age that we are co-creating now with member states in the context of the Social Protection Committee. How we monitor all of this? We monitor it together with the committees, the Social Protection Committee, as I've mentioned, but also in the framework of the European semester. This is basically a yearly process in which the Commission provides recommendations to the member states about areas for improvement. And here, this year, still 2025, we managed to have no less than 15 country-specific recommendations dedicated to long-term care, so 15 out of 27 member states, many looking at adequacy, but also at the workforce aspects that need improving, and so on and so forth. My last slide is really just a shared resource, nothing to speak about. Here you have the links to mostly everything I've been mentioning as resources, so I hope that you have the time and interest to dig in this further after the session. Thank you very much, and now I think I can pass the floor to my co-panelists. But I don't know who will go first. So Adelina, if you could help me.
Yes, in the list we had Ognian Droumev going first from Bulgaria, and then
I see Ognian
Tina.
is here. Yes, I see Ognian already. So the floor to you, Ognian.
Hi, Flaviana, Adelina, Nas. Thank you for organizing this event. And I hope we will receive the great learning from it later after the event closes. Thank you also for inviting Bulgaria and me to make this presentation about the reform of social services in Bulgaria, which will go through several things regarding the context of the reform. The focus will be on a national map of state-funded social services and the quality of social services, which affects all social services, not only the state-funded ones. Of course, we will present some of the challenges which were addressed and why these two documents are needed, because there are many other things in the policy segment which happened and they continue to happen in Bulgaria. But we thought this might be of interest for you. Then some ideas about what next and what results are achieved so far, and the final conclusions from what we mean to have here. Okay, Bulgaria.
Hi, Ognian. Sorry, just to let you know, your slides haven't gone into presenter mode. I don't know if you want to try one more time. Sounds good. I'll move it there, and then you just tell me next slide every time.
Okay, well, Bulgaria has very similar problems and context issues as the other countries which were here. And when we met on the AU level, we hear almost one and the same: aging population, high mortality rates, territorial discrepancies, differences between urban and rural areas, and so on. The Bulgarian population is about 6.5 million, and just to mention, 40 years ago, we were about almost to reach 9 million. So the country is really decreasing in population terms, and the death rates exceed the birth rates by about 80%. This means that the aging is a real issue. This was realized in Bulgaria in the 2015-14, in that period, where we presented and it was developed a national long-term care strategy, one quite early document, which is still effective. In this context, the system of social services, which is now in the reform, is characterized by several features. The one thing is that it is decentralized, and this is for more than 20 years, and it proves to be a good setup for the services, because before that, like almost 30 years ago, so services were completely state-owned. In 2020, a new Social Service Act entered into force, and what is, I would say, revolutionary with that document is that the concept of services was completely changed. So they are now considered not to be places or facilities or centers as they are still, but defined on, if you wish, on a philosophical level as activities. This creates some issues, I must tell you, and later on we can speak on that, because people hard understand this concept always. We try to establish a system which is very individualized, person-centered, even in the monitoring and quality control functions. The role of the beneficiary is crucial for assessing the effect of the service. Of course, this is related to the human rights agenda and the concept. And on the normative side back, what is introduced with the new system is licensing of the private service providers. I know some people criticize this setup, saying, okay, but why municipalities do not license? The thing is that the municipalities, they have a role in social protection, child protection, so they're on the ground in order to develop their own services, and then the private sector is not complementary, but it comes in addition to that role. There are 8 social service principles. I'm not going to read all of them. Just to highlight, individualization of support is one of the crucial one, because also to mention, we come from an era like 25, 30 years ago with a very, very institutionalized system where people, if they are in need, were placed in residential institutions, large numbers in isolated areas and so on. So this is in process to be restructured, to be changed. And therefore, one of the principles is prevention of institutionalization. We have a ban to institutionalize children below 3. And at all, if institution, this is only if there's extremely no other option there to use. Participation, I mentioned it already. Then we can jump to the next slide, please, with some figures. The previous one with the charts. Okay, this one. These figures, they are for state-funded social services. From 21 to 2025, the increase is about 150%, and the annual growth is about 37%. In the same time, the number of social services also increased by some 15%. Comparable increase is of their capacity, which is about 16.5%. Of course, we're not going to read all these numbers that are just illustrative for this what we are talking about. Big portion of the increase is in the segment of community-based services, not the residential and the institution one. Important to mention in this balloon of services, we find the LTC, the long-term care services also. Then the next slide will speak about our reform context. So this is where we were. I mentioned already the issue of aging population and increasing care needs for people who are in need in old age. And nowadays, there's more and more realization the issue about loneliness, which affects to biggest extent the women, the older women when their spouses are no longer there. And of course, the social service provider must address this problem. Another challenge was in Bulgaria, and it is still there, territorial discrepancies and fragmentation of services. We have areas which are pioneers and they are excellent and very good, while on the other parts of the map of the country, this is vice versa. People are not interested. The local authorities are not interested, maybe. And it's not only the money factor here. We have identified that even some fantasy is needed more in some cases where people just to think they can create not a residential institution, but have something what is community-based, home-based, and so on. Here's some cultural things also. There was I would not say a huge discussion about the need for changes in the normative regulation, and this is from where the Social Service Act stands. I think the process of developing the act was for several years, and it also involved some institutional redesigns of the system. I will give you later such an example with establishment of the local agency on the quality of social services, while in the same time, the old inspectorate on social services was closed. Something what I call as a sociological factor is that the deinstitutionalization of child protection system gave a momentum to feed the deinstitutionalization and shift towards community-based services in the LTC sector, the long-term care sector. So I would say, and many people, when we're now working on deinstitutionalization in the long-term care, We take models, examples, but also bad lessons from the deinstitutionalization of childcare. Yes, let's move to the other slide, which is a little bit elaboration of what I was talking about now. And this is the interplay between several factors on the policy and normative and institutional setup, which then affect the practice and behavior. I mentioned already that on a policy, we have a national strategy on long-term care, which is lasting until 2035. There are two action plans for its implementation. The plan 2018-21 is already implemented and reported. The other one, 2022-27, is ongoing. And this is where we collaborate with the European Commission when reporting on the Council recommendation. We're using our national planning reporting and to produce the European required one. On the normative side, I mentioned the Social Service Act, and there are several bylaws associated with that act. There are still two to be adopted, and they're in process of finalization. And as I mentioned, through this act, we introduced the system of licensing. And another institutional change which happened is the establishment of the Agency for the Quality of Social Services. It started 2020, I think, to be operational, and it is a nationwide agency which controls and provides methodological support not only to the state-funded social services, but also to the private ones, which are run by businesses or NGOs. This, of course, affects changes in the practice and behavior. Behavior, as you know, is the most difficult to change one. In the practice, what we have now, it's a little bit confusing, might be for external, even for internal parties. We have the old and the new system run in parallel. And this creates confusions, creates challenges, and lessons learned, of course. So we now try to close these two streams into one and to have at some point of time, I don't know when, a completely reformed system. So when we say reform in the social service system in Bulgaria, we should bear in mind that this is not complete. This is still ongoing, in my view, at least 2 more years to get there. Then we can go to the next slide. I need to run a little bit faster, maybe. Okay, we're going to speak national map and the ordinance. Just to mention that these tools are normative acts. Next slide. The national map of social services, it is about state-funded services. It is a 10-year document. Its validity is for 10 years. And based on that national map, each municipality has to develop annual maps of social services. This is first document from such scale and such character in the country. And the approach which is introduced here is objective one, not on a historical side. So before that, people just knew what is there, what was there. Okay, we are going to do this and that. So now it's a little bit not like this. This evidence-based criteria should determine the type and the volume of the service. We try to address the territorial issue through the municipal plans. And of course, this affects the funding to a large extent. As I mentioned before, not all municipalities are equally interested into social service development, and this is one of the challenge which is ongoing in the reform system there. Of course, we work with we are using the EU models and standards for requirements for accessibility and for social services at all. Interesting to mention how the plan was developed. It was 1 year exercise. It started, I call it top-down, top approach. So from the central agency, materials were distributed to municipalities. Then the municipalities needed to communicate, ensure participation, make meetings and so on with the local service providers and the communities, not only the professional ones. Their drafts were then reviewed by, again, on a central level, and some adjustments were made there. The document was publicly discussed. So it is to a large extent consent document, although there are some critiques about it. Let's go to the next one, which is ordinance on the social quality. As I mentioned before, these two documents are normative facts, so they have lawful power. The quality of social services, it is structured in three major domains: organization and management, staff requirement, and development workforce. And here, important to mention, we introduced minimum requirement for training and social service supervision. And the third segment of the ordinance is about results and the effects which are to be achieved. Again, interesting thing, some of the social service provider would see trainings and the supervision as a cost. So we try to convince them, listen, people, these are investment in your professional part of the business. But well, how we shall release the people to make this training and so on. So again, we have this mutual kind of learning agenda here, and to convince people to advocate that this is needed. It's not just costs there. The main institution dealing with the quality of social services is the agency, which I mentioned before. But then in Bulgaria, we have a tripartite system of monitoring. So each social service provider needs to monitor internally the social service and produce a program on quality development. Then municipality have their also authorities and obligation in monitoring of the social services, and the agency. The agency is the organ which can issue normative penalties, but also they select each year a book, if you wish, of good practices from their work, from what they observe on the ground. Ordinance, the standards of social services are measurable. Each standard is attached with criteria and measurable indicators. Around different standards is different. 30 to 40% of the indicators are qualitative indicators. They obtained through observation, interviews, discussions, and so on. Let's go to the next one, which is challenges addressed by reform. Okay, we have spoken about that. Inequality of the access between the areas, need to clear standards on quality. And there's another positive side effect of this, and which affects the expectations and bringing them together on equal level from the user side and from the service provider side. Another challenge was the over-reliance on residential institution, which I think is a good news. It's not always the case here in Bulgaria. Workforce shortages, I think it's very hard to address this one. And some people would say we don't know what to do. The reliance on the volunteers or informal care do not provide, in our view, the adequate response, because then we miss the professional part of the story. In the new system, also, we introduced integrated health and social services. The not so good news is that they are still not very, very good developed. But of course, big part of the population needs exactly such type of service where you have health and you have social and maybe educational working together. But imagine what happens. Each system has its sovereign normative facts and protocols, and to combine these two things or three things is difficult. Then next slide is about results and expected impact. So we have here more accurate planning of services and investment based on real needs. Improved coherence of the system for long-term care and alignment with EU principles, but also local, national requirements. Better defined expectations for providers and improved quality monitoring, what I mentioned before. By having just at hand the standards here, everybody can tell you this is to be done this and that way, and this can be achieved, respectively not achieved. The system is person-centered, and in the reform process, there is a good cooperation, I would say, with municipalities and the local. Some of them are national-wide social service providers, including NGOs. Then what is next? Let's go to the next one. To implement the national mapping practice, this means that we adopted it last year, so still it is to be fully implemented. The same applies for the quality standards, and the issue here is, again, we have the two systems run in parallel. The other priority would be to develop the integrated services, including the home-based care and mobile services. Good example here was done by Telecare, pilot project which was implemented for 2 or 3 years period. Workforce development challenges to be addressed, and the focus is now more on prevention, early intervention, I would say, home-based services. One new service which was introduced 3 years ago is the assistant support, where assistants, they go at homes of the people who are in need. And then final conclusions. Okay, maybe just I would point out him on the EU support, how we see it. Well, big chunk of it, of course, is the money. But then we learned a lot from the peer reviews, and sometimes inspirations, even if you wish, ideas, what to have, how to do it, models, and so on. And just to remind, the DI process, the deinstitutionalization process, was done with the great support of the EU, and in that time, the World Bank. Okay, the last slide is one big thank you for your attention.
Thank you so much. Flaviana,
So I just wanted to do the moderation act of introducing and welcoming Tina Lipar from Slovenia to present the recent reform on long-term care and the Social Insurance Act for long-term care. Thank you and welcome, Tina.
Thank you, Flaviana. So firstly, I would like to thank the organizers for the opportunity to present the long-term care system and long-term care insurance in Slovenia. My name is Tina Lipar. I work at the Ministry of Solidarity-Based Future at the sector for the long-term care and the institutionalization. Our reform is based on the Long-Term Care Act that was adopted in July 2023, marking an important step towards modernizing the long-term care system in Slovenia. The Act aims to strengthen the community-based services and improve access to both institutional and home care. Currently, around 20,000 people in Slovenia receive care in long-term care institutions, and only little less than 9,000 receive home care services. This is why the Act places a strong emphasis on upgrading and expanding home care support. A key component of the Act is the establishment of a single entry point where individuals can access their long-term care needs and exercise their rights in the one place. At the same time, the focus is put on the digitalization process to speed up decision-making, reduce administrative burdens, and improve service monitoring. The Act also focuses on strengthening the workforce through additional training, new standards, and new positions within long-term care, such as long-term care coordinators. Another important priority is prevention to support older adults in maintaining independence. And last but not least, the goal of the Long-Term Care Act is clear: to make long-term care accessible and available to everyone who needs it. Let me say a few words about how people become entitled to long-term care benefits in Slovenia. Entry points for long-term care are located at social work centers. Their work specialists who provide information and advice regarding the long-term care rights, accept applications for the exercise of these rights, and use a special assessment scale to determine whether individuals are eligible for long-term care benefits. This scale measures how well people can still take care of themselves, so it basically measures independence of the people. The assessment is carried out in the person's home. If at least a mild limitation of independence is identified, the person becomes eligible for long-term care and can choose from the following rights. The rights are formal care in institution, formal care at home, cash benefit, or a carer for a family member. People who choose formal long-term care at home or in institution can receive services to help with activities of daily living, such as bathing, dressing, feeding, instrumental activities of daily living, such as cleaning, laundry, escort to the store, or nursing care services, such as medical administration, enteral feeding. Both people who choose long-term care in institutions and people who choose long-term care in home are also entitled to services for strengthening and maintaining independence. But only people who choose formal long-term care at home are entitled to e-care. E-care is in fact a social alarm system that allows people to trigger a call to assistance center in the event of accident or sickness. This center then receives the alarm and afterwards organizes the necessary help. Beneficiaries of long-term care can also choose either a cash benefit or a carer for a family member. A cash benefit is, in fact, monthly financial benefit intended to cover care-related expenses. A carer for a family member is a family member who has left the labor market in order to provide care to their relative. They are entitled to compensation for lost income and are also entitled to paid social insurance contribution. In addition, they are eligible for 21 days of respite care per year. As you saw on both slides, all term care users are also visited by long-term care coordinators who are employed by long-term care providers, since one of their most important tasks is monitoring the adequacy of care provided. In Slovenia, long-term care is financed through three sources: compulsory insurance, state budget funds, and user participation. Mandatory insurance contributions provide around 700 million euros per year. The state budget adds slightly less than 200 million euros per year, and user participation from 2027 onward will be only if the funds from insurance contributions are not sufficient. About compulsory insurance contribution. Here, I would like to say that in Slovenia, all individuals that are included within health insurance are automatically included in long-term care insurance. The Health Insurance Institute of Slovenia is collecting this contribution and financing long-term care entitlements and services. About the contribution, employers and employees each have to contribute 1% of the gross salary, while pensioners contribute 1% of their pensions. Persons receiving financial social assistance are exempt from paying these contributions. So this was my last slide about long-term care reform in Slovenia. It was just a short presentation, and I would love to answer any questions that arise. So thank you very much for the opportunity, and thank you very much for your attention. And I'm giving back the floor.
Right. So I see some questions. First of all, I'd like to say thank you to all three speakers, to Flaviana, Ognian, and Tina. Thanks for these amazing overviews. Also, thank you for sharing the challenges, especially in Bulgaria. And it's very exciting as well to learn about having a new social insurance system in Europe. From Slovenia. I noticed in the chat there's already some discussion, and so I think there's a bit of a discussion around the institutionalization and what it means as well, and I think it's really perhaps important that we take a bit of a moment, and perhaps each of the three speakers could share your thoughts on this. So I don't know if you can see in the chat, but in some countries we have few people in residential care, and then there's this issue of whether all institutional care is run as an institution or whether they can also be run in a way that is more person-centered. So I don't know, Flaviana, if you have a more general comment on what you see across the EU in the institutionalization.
Yeah, first of all, maybe a small terminological clarification, because oftentimes residential care is automatically put on the same. There's an equal sign put between residential care and institution. In the and which is not correct, because we look at institutions as, if I may be very brutal in my, as bad quality residential care. And we distinguish in the recommendation and in the EU level, statistics and policy guidance between legitimate residential care, which should be compliant with all of the quality standards that the Commission has set out in the recommendation, including supporting autonomy, being integrated in the community, joint participation in decision-making, and so on and so forth. So this is one form of care, one care option that for us it is absolutely legitimate, and this should eventually it should be the choice of the person with care needs to opt between home care and day care and residential care, supplemented by informal care, or mixing all of this in the way that it addresses his or her care needs. So I think that the idea of policy making is to lay out the options and then allow people to make their choices. It's important that this is not a constrained choice. That is very important, because what happens often in reality is that people end up in residential care simply because there's no home care or community-based care. So this is not okay. Equally, people end up only relying on informal care because there's no formal care available. This is also not okay. So I think that we should really be, from a policy perspective, our line here is to make sure that the residential care is of good quality, that people who use this option do it not because they don't have other options. In this, especially when it comes to residential care, also public and private actors really stick to the same quality standards and are part of the same quality assurance mechanisms that ensure that the quality is there regardless of the profile of the provider. So this would be my not so quick reflection on this topic.
Thank you. And perhaps, Ognian, if you'd like to comment from the Bulgarian perspective on the processes of deinstitutionalization.
I think I mentioned some of the aspects before that. In the long-term care, really, we took the ideas or the models from the child care deinstitutionalization process. But here is something, as Flaviana said, terminologically, and in our case, normatively, to say, if you wish, I don't know if to clarify, but just to tell what is the reality. The old homes for people with disabilities, several types of such homes. We have 5 different types of homes still operating in Bulgaria. They are in process of closure. They are not considered as social services. They are considered as specialized institutions. They are inherited from the previous era. Many of people who are there, they live in such an environment for entire their life. So it's a little bit like the cave of the plateau. They simply don't have any outside of the institution experience in their life. For these cases, it's impossible to find relatives, to find places where they can be accommodated, where they could live. For some of them, this is done through small-scale residential homes, residential care facilities, which are then obliged to follow the quality standards for social services. And here you can find all this requirement about individual support, about limitations of how many, no more than 2 people in one living room, or even 1 per living room. There are special requirements about all different aspects who affect their rights. But how to say, the situation is now that under the recovery and resilience plans, the old specialized institutions are in process to be, so we build now new social services where people should be transferred at some point of time into these new residential care facilities for those of them, but this is the majority for whom no other options are available.
Thank you. And Tina, would you like to talk a bit about this in your context in Slovenia?
Thank you. As you saw in my presentation, in Slovenia right now, there are a lot of people that receive long-term care in institutions, like 20,000 people, and at home a little less than 9,000 people. So the aim of our long-term care act is to shift this from institutional care to care at home. But like many other countries, we are facing staffing challenges, so that certainly is slowing down the process. But our goal in Slovenia is and remains that for people are able to receive care in the place they want to receive care, and the research shows that this is mostly at home. So our narrative is to make home care more available and accessible to all who want this kind of care. Thank you.
Thank you very much. And I'm wondering if we have any other questions. Please feel free to raise your hand if you'd like to ask anything. We have time for about 1 more question. And of course, the presenters can also to ask each other questions if you have anything in mind. And I don't see anything there, but there is a comment about care integration and the importance, I think it's from Heidemarie Stavlinger, the importance of building links with the health system. Definitely another challenge there that I think we have across countries. And I was wondering, yeah, if Tina, Ognian, if from your perspective, is this something that you feel your reforms can address, or is it something that maybe is more for the future?
This is something that our reform should definitely address, but in the future, probably in next few years, because right now we are establishing this system. We are at the very beginning. So in the future, I don't know, in the next 5 years, this is definitely the challenge that we should address so that social care, long-term care, and healthcare systems are connected in a way that people receives all the care that they need in the connected way.
Thank you.
You
You
know,
want to come in, Ognian? Yeah.
there's a hand raised there.
That's okay. You can quickly comment on integration, then we move to Jill.
I
Jirka.
mentioned there are issues with cooperating between the two systems, and this is not because people don't want to, but in many cases the institutional and the normative history, if you wish, they present a kind of a burden. We have some good models here, but then again, this need to be replicated and roll out nationwide. And the law, the Social Service Act, explicitly introduces this integrated health and social services. So this need to be implemented.
Thank you. And now Jirka, yes.
Hello, everyone. Many thanks for being able to participate and follow this very interesting event. My question is directed to the Bulgarian case. I'm very grateful for the presentation, and I have a question. During your presentation, you mentioned the institution types inherited from the previous era in Bulgaria. And I just would kindly inquire whether what are the plans of the government in terms of these institutions towards the future? Are they going to be transformed or abandoned and abolished altogether? If you can expand a bit on the situation of these facilities, thank you very much.
Yes, they are going to be not demolished, and nobody is going to be abandoned. So I mentioned now we're in process of developing, I read now, 240 services. These are residential type of services for the homes, for the users, clients of the current specialized institutions for people with disabilities, which are spread in 62 municipalities. The overall number of institutions of these homes is about, I don't have the exact, need to calculate it here. It's more than 60. So it's a long-term process already. I think about around 20 are closed already, and people are transferred to another residential care facilities, which are small sized. We look at this that they are not placed in isolated places, that they have kind of normal environment, and the needed services what these people require should be there, because in our current system the residential care service do not provide everything, but if you need, for example, kind of advocacy activity, this is a separate service which can be provided by external social service provider, or provided within the institutions or outside of them. it's different. It's kind of a puzzle where you need to mix this different pieces. Back to your question, yes, it is a long-standing process. As per law, the Social Service Act, the specialized residential institutions must be closed by 2035. And now we are in the phase until 27, and the last phase will be between 2027 and 35.
Thank you very much. And with this, we're going to end this first session of the European part of this event. So thank you so much for joining me, thanking the speakers. You can use your virtual hands to clap. And yeah, we're now going to move to a different part of the session. We're now going to go into one of these myths about long-term